Okay, looks like the numbers are starting to plateau off, so I'm going to get us started. Good afternoon, everyone. I'm Lynn Richardson. I'm the founding co-director of the Institute for Health Equity Research, and I'm very excited to welcome you to this session of our IHER Health Equity Seminar Series. We do sponsor these sessions, and they're open to the entire Mount Sinai community and beyond. And we're particularly excited today to have someone who I actually have known for a very long time when we were both much younger and in a health services research fellowship program. I had the great pleasure of meeting Dr. Marie Bernard and ran into her at a meeting a few months ago, and she graciously agreed to come and talk to us about what is going on within NIH in terms of diversity, equity, inclusion, and accessibility, and particularly with respect to the diversity of the scientific workforce. So it's a great pleasure to have Dr. Bernard here. She is currently the Chief Officer for Scientific Workforce Diversity at the National Institutes of Health, where she really leads NIH thought regarding the science of scientific workforce diversity, ensuring that the full range of talent is accessed to promote scientific creativity and innovation. She co-led the development of the NIH-wide Strategic Plan for Diversity, Equity, Inclusion, and Accessibility, DEIA, and is currently working on its implementation. She co-chairs the advisory committee to the NIH Director Working Group on Diversity, the NIH Steering Committee Working Group on DEIA, and the NIH Unite initiative to end structural racism. And I think we will be hearing a bit about all of those efforts during her talk. Prior to assuming her current role, she was the Deputy Director of the National Institute on Aging, where she led a broad range of activities, including co-chairing two of the DHHS Healthy People objectives, the one for older adults and the one on dementia. Her own area of research focuses on nutrition and function in older adults, with a particular focus on underrepresented populations. She went to NIH from a position as professor and founding chair of geriatrics at the University of Oklahoma College of Medicine and associate chief of staff for geriatrics and extended care at Oklahoma City Veteran Affairs Medical Center. Dr. Bernard earned her BA from Bryn Mawr and her MD from the University of Pennsylvania. She trained in internal medicine at Temple and received additional training, again, as I mentioned, in the AAMC Health Services Research Institute, as well as the Geriatric Education Center of Pennsylvania and the Wharton School Executives Development Program. It is my great pleasure to introduce Dr. Marie Bernard. As we get started, there is a Q&A function. If you have questions that you would like Dr. Bernard to address, please use the Q&A function to send us those. And at the end of her remarks, we will get to as many of your questions as we can. So with that, please take it away, Dr. Bernard.
Thank you so much, Dr. Richardson. Yes, we've known each other since we were babes.
Baby.
And it was such a delight to see you recently at that meeting. So what I'm going to do over the course of the next, 40 minutes or so is, as mentioned, talk to you about diversity, equity, inclusion, and accessibility, or DEIA, from the perspective of the National Institutes of Health. I'll talk about why it's important to focus on this, our strategic plan, what I as the COSWD am leading, and this NIH Unite initiative. And let me start with this theoretic framework that's shown here that, as we talked about in Nature Medicine a couple of years ago, represents why we think diversity is important. Because the sorts of problems we're trying to address in biomedical and behavioral research are like trying to describe an elephant sightlessly. You have to go at it from a lot of different perspectives to begin to get the right answers, the true answers. And it's not just a theoretic framework, there are data that support this. And it's really important to focus on the data, particularly in these days, all sorts of questions as to why diversity. The classic article by Freeman and Wong in 2015 that looked at some 2.5 million articles. And the takeaway is at the top: diversity results in more productive collaborations. They wanted to see whether homophily, the authors being seemingly of the same ethnicity, was associated with the impact factor of the journal in which the article was published and the frequency with which it was cited. And again, takeaway point: lower impact journals, fewer citations. What are the data? They have this homophily index where they determine the ethnicity of the authors based upon an algorithm. It went through all 2.5 million articles and classified the author's ethnicity. It's not a perfect tool, but it was consistently applied. And the higher the homophily index, the more alike the authors appeared to be. And as you can see, as you go across this row, the homophily index goes down progressively. And in the bottom row, the impact factor where the article is published goes up. It's associated with the number of authors, and I know you're thinking that a 10-author paper is probably talking about different science than a 2-author paper, but whether they looked at it in terms of the ethnicity of the authors or the geographic diversity of the authors based on the addresses where they were publishing from, or information diversity, the number of references in the paper, the more homogeneous, the lower the impact factor, and the less frequently the article was to be cited. Another lovely example is this by Haynes and colleagues, where they looked at ornithology and a component of it that was looking at birdsong. And they found in that component that it was initially a male-dominated field, and there was a dominant paradigm about birdsong patterns. But in retrospect, it was based upon looking primarily at male birds. As women entered the field, it was found that there were gender-based differences in birdsong. The paradigm was subverted because women were looking more broadly. They had a differing perspective. And then there's this lovely report by Kozlowski and colleagues from January of 2022, where they looked at 5 million articles. And in this case, they wanted to look at gender, race, and ethnicity. So you see a heat map here. The far left column is white men, Black men, Latinos, Asian men, Asian women, Latinas, Black women, and white women. And as you can see in the upper right-hand corner, the women, Latinas, Black women, white women, tended to publish quite a bit in health, psychology, and the arts, men much less so. And the bottom right-hand corner, you see that women tended not to publish as much in engineering, technology, math, and physics, which was a highly published area for men. They also found that the women published less than the men, which is a known phenomenon, and led to them coming to the conclusion that if there were equal degree of publication between men and women, that there would be a different focus in the sciences, given the distribution of focus of the various genders and races. We had a seminar to pull together all of the current thought of scientific workforce diversities in what we call our scientific workforce diversity seminar a year ago in May. And I would really refer you to that for an even more comprehensive summary. We had a star-studded cast of OSTP leader, Dr. Laurel Smith-Dorr from the University of Massachusetts, Dr. Freeman from the Freeman and Wong paper from Harvard, Dr. Jennifer Kwan from California State, George Santangelo from NIH, and Shirley Tillman, who gave concluding remarks, former president of Princeton. The proceedings from that may be very helpful if you want to get into greater detail about the impact of scientific workforce diversity on creativity and innovation. But bottom line, we think it's important. Even more compelling, I can't get away from my roots as a geriatrician, is the story of Aduhelm. Aduhelm was the first out of the box 2.5 years ago now to be approved as a therapeutic for Alzheimer's disease. It is an anti-amyloid drug that seemed, some controversy about the data, but seemed to perhaps slow the accumulation of amyloid plaques and perhaps could be helpful to people. And it got accelerated approval by the FDA. It's problematic for many reasons, but one of the big issues that I see as a geriatrician and someone who's interested in underrepresented populations is that you had to have either mild cognitive impairment or early Alzheimer's disease to be able to be eligible to study. And that's a diagnosis that's often missed. It's missed frequently in all groups. 41% non-Hispanic whites have it missed, but 46% of non-Hispanic Blacks and 54% of Hispanics also have it missed. So at the get-go, the likelihood that you would have a good representation of non-Hispanic Blacks and Hispanics in the studies that led to approval of this drug was limited. And then when you look at who actually was in the study, 89% of the participants were non-Hispanic whites and 9% were Asian, leaving just 2% for other populations. And yet when you look at the distribution of Alzheimer's in the United States, at least, it's much more prevalent in African Americans and Blacks and Hispanics than in other populations. And there's a lot of other data to suggest that there are differences in the way in which the illness presents itself in those populations. And thus it makes you wonder how truly generalizable the data are from this study by Biogen that got approved by the FDA. Again, very controversial for a lot of other reasons, but that's an issue there. We know that Black and African American, Hispanic, and Native American physicians are more likely than white physicians to practice in underserved communities, and that patients, when given a choice, are more likely to select a health professional of their own racial or ethnic background. And that can really very much influence who ends up in these clinical studies. And I can certainly say from my role as the deputy director at NIH that you didn't see a lot of diversity among the scientists who were developing these studies, and it probably translated into not a lot of diversity among the group that was funded by Biogen, and thus not a very diverse population that ended up in the study that led to the approval of the drug. From our viewpoint, it's really important to have inclusion because it leads to excellence. It is not a social justice issue. It's an issue of better science. And as you can see, potentially more generalizable clinical data from clinical studies. Do we use the full talent pool that's out there? Unfortunately not. These are data from 2020 and 2019, hasn't changed remarkably in the last couple of years, looking at the representation by race and ethnicity in people who've gotten R01 grants from the NIH, the brass ring that leads to tenure if one's at an institution that provides a tenure, still representation in the general STEM population, and then representation in the general population in the United States. And as you can see, for non-Hispanic whites, very good representation. For Asians, very good representation. But there's some opportunity for more inclusion of Hispanics and Latinos and Blacks and African Americans. And if we tried to show American Indians and Alaska Natives, the numbers are so very small that they wouldn't be seen on this graph. There are other components of diversity, things like having a disability, coming from a sex gender minority group that we don't have as much data on, unfortunately. Hopefully, as time goes on, we will have more so that we can make comparisons. But certainly from the standpoint of male versus female, as we look through the professoriate, AAMC data, at the instructor level, women are well represented. Green here is underrepresented women, orange is well represented women, red is underrepresented men, blue is well represented men. And at the instructor level, percentage-wise, there are actually more women than men. But as you go through the professoriate to the level of a full professor and a department chair, there's still some room for enhanced diversity. And these are the people who are policymakers and gatekeepers for resources and opportunities. So what do you do about this? We also wrote about this in a Nature article early years, 2022. Okay, I think it was January, February 2022, where we talked. This is in terms of inclusive excellence for women, but it's really applicable for all groups that we find are not well represented. That there needs to be a demonstrable leadership support for enhancing inclusion. You have to have some plans and some action-oriented approaches You have to pay attention to having a culture of inclusion. You have to see what are best practices and utilize them. And you have to recognize that the way forward for someone who comes from an underrepresented group may not be the usual way forward, and there needs to be enhanced flexibility and options. So what I'll be showing you subsequently are some of the things we've done at NIH to address that. For instance, we released a strategic plan for diversity, equity, inclusion, and accessibility. Again, I'll say DEIA from here on, in March of this year, that outlines how we envision going forward for the next 5 years. This is our strategic framework, our guide document, and something that should give you a sense of what might anticipate funding opportunities go forward. It was generated by a combination of a mandate to have a DEIA plan for the federal workforce and language in the budget for NIH in fiscal year 21 that called for a DEI strategic plan. Our plan talks in terms of our mission being to embrace, integrate, and strengthen diversity, equity, inclusion, and accessibility across all of our activities in the service of our mission, with the vision of being a people-centered organization representative of our nation's diversity, where everyone has a sense of belonging. There are 3 objectives to it: to grow and sustain DEIA through structural and cultural change, to implement organizational practices to center and prioritize DEIA in the workforce, and to advance DEIA through research, very much externally facing, these other 2 more internally facing. It is representative of everything that's going on across NIH. We have the Minority Health and Health Disparities Research Plan, Tribal Health Research Plan, Women's Health Research Plan, the COSWD Plan, a Section to Minority Research Plan. All of these are to be represented in this plan, as well as what the institutes and centers are doing. Some examples, that's the umbrella that was supposed to be earlier. We have a Native American Health Research Centers for Health that had been around for quite a while. When I was a faculty member at University of Oklahoma, I know the College of Public Health was very proud of their relationship with the Cherokee Nation with the NARCH grant. These grants are meant to help tribes to address research and health needs and to develop leaders among American and Alaska Native researchers. The more recent Community Engagement Alliance, again, team clearly developed since the pandemic, was brought about by our seeing the need to work with the communities that were disproportionately impacted by COVID and not having those connections. We had to develop very quickly relationships with communities, with researchers who are already there. And it worked. We were ultimately able to get the linkages that were needed to be able to develop therapeutics and vaccines, and then education about vaccines as the vaccines became available. It was also very clear, however, that helicoptering in and out was not the way to do things. And so the SEAL Alliance has been renewed to be an ongoing sort of relationship with communities so that when the next pandemic comes, unfortunately, we probably will have another, we will be better positioned to be able to be helpful. And then there is the position I served, the Chief Officer for Scientific Workforce Diversity. I'm very honored to be the second COSWD for NIH. The first one was Dr. Hannah Ballantyne from Stanford. She came on board in 2014. Why was this position developed? Because in 2011, Donna Ginter and colleagues, including Bernard Kington, who was the Principal Deputy Director at NIH at that time, published an article in Science that was an analysis of the success in getting R01 type grant funding from NIH based upon race ethnicity. Initially, what they found was that across the board, people who were not non-Hispanic whites were at a disadvantage. African Americans, Black, Hispanics, Latinos, American Indians, Alaska Natives, Asians. However, as they evaluated and controlled for multiple factors, English as a first language, where you trained, where you were working, et cetera, most of those differences disappeared except for African Americans and Blacks, where there was a persistent 10-point disadvantage. Francis Collins, the then NIH director, turned to his advisory committee to ask what could be done about this. And one of their recommendations was establishing a COSWD. I'm very grateful to Hannah for all the work that she did from 2014 to October 2020 to develop a foundation upon which the team that I now lead has been able to build. I came in as the acting COSWD in October 2020, and I was honored to be selected as the permanent COSWD that following May. And we put out our strategic plan in March of 2022. We talk about enabling NIH and NIH-funded institutions to benefit from the nation's full range of talent to foster creativity and innovation in science. If we are going to maintain our worldwide leadership in research, we have to do this. We have to have the different perspectives, and we have to take advantage of the talent that's out there that's progressively more diverse in younger and younger populations. Our mission is to be the NIH thought leader in the science and scientific workforce diversity using evidence-based approaches to catalyze cultures of inclusive excellence. How do we do this? By building the evidence using NIH as a test bed, by disseminating the evidence across the biomedical and behavioral research workforce ecosystem, and by acting on the evidence. And just to illustrate, this is the COSWD, this is the role I sit in. I report directly to the NIH director, like Jiminy Cricket, you might say. I co-lead, as mentioned, the Advisory Committee to Director Working Group on Diversity, which is a subgroup of the NIH, the Advisory Committee to the Director, very influential outside scientists. And I also co-lead the overall NIH DEIA working group that considers diversity issues and work with all of the institutes and centers. An example of our building the evidence is something that's called that we call the 21st Century Scholars Program. We did this because we can see that program officers and scientific review officers, those NIH staffers that you make contact with when you're applying for a grant or when you're going to be involved with the review panel, are really important and really influential. And our hypothesis is that if we can train a cadre of DEI advocates among those individuals, that could make a difference in how broadly written a notice of funding opportunity might be, or who gets selected for discretionary pay. You know about discretionary pay. The institutes and centers go down the line, pay as many grants as they can, and then they get to a point where they, bunch of grants that have the same score. So who do you pay? Program officers, often the person who advocates for that. And our goal is to make sure that the program officers think broadly of who are good scientists to benefit from that. So we are targeting newly hired program officers and scientific review officers. We're bringing them together as a group, 15 at a time, to work on thinking about inclusive culture. They're getting mentoring, they're building community, they're enhancing their work skills. We are graduating our second cohort next week. Our hope is that at the end of 4 to 5 years, we will have a critical mass of these program officers and senior and scientific review officers that will have an influence. And we'll see whether that proves to be the case. As I mentioned, we have the Scientific Workforce Diversity Seminar Series. Our last for the 22-23 season was talking about mentoring. Juan Amador, CEO for this, our executive director for the Society for the Advancement of Chicanos, Hispanics, and Native Americans in Science, or SACNAS, was one of our reactants. Angela Byers-Winston, who led the NASM study on mentoring, was one of the presenters. Jesse Darrow, who is in charge of the advanced program at the National Science Foundation, another mentoring program, spoke. Christine Fund, who's the principal investigator in the National Research Mentoring Network, another outcome from the Ginter study, spoke. And Dr. Karen Salt from the UK Research and Innovation Institute gave an international perspective of mentoring. A wonderful panel, wonderful outcome and evidence. If you're interested in seeing the slides, the video cast, just go to diversity.nih.gov. You might want to peruse all of the 8 offerings that have been done in the last couple of years. There are meeting proceedings for all of them except this one. We're still working on that. We think it's important that we always be evidence-based in the things that we're doing in this space, and we're trying to share and spread the evidence. And then acting on the evidence, we know that mentoring is really important to allow people to be successful in science, and that mentoring is often undercompensated, if compensated at all. So last year, and then again this year, we've given the opportunity for funded scientists to get an administrative supplement to recognize their excellence in DEIA mentorship, to allow them to continue doing the mentoring, or more in mentoring, or more in their research. You see here the fiscal year 22 awardees. We were able to give a third more awards than had been planned in the COSWD budget, because so many of the institutes and centers thought it was a good idea. And we will add to this map at the end of this fiscal year, September 30th, after we've gotten everything straightened out with the awardees for fiscal year 23. But we had a really nice, robust response in fiscal year 23, so much so that we will do it again for fiscal year 24. So if you are one of those mentors who's done a great job and you don't have a lot of other NIH grants, you can't have more than one independent NIH grant, think about this, keep an eye out, watch diversity.nih.gov. And then there's the NIH Unite initiative that has the robust or the audacious goal of ending structural racism, as the URL says here. This came about by the events of 2020, where we all saw the disparate morbidity and mortality for populations of color due to COVID-19. We all saw the videotaped murder of George Floyd and other racial violence. Just after we publicly unveiled this, February 26, 2021, at a special meeting of the advisory committee to the director, we saw the killings of 6 Asian women in Atlanta. This all brought into sharp highlight for NIH the reality of racial and ethnic injustice in our country. Some really intense conversations internally the summer of 2020. And it compelled us to examine both internally and externally with the racial and ethnic equity lens, what are we doing? What can we be doing differently? And I'm happy to say 2.5 years since this was publicly unveiled, there's a lot. There have been a lot of developments, a lot of new initiatives, and they're broadly applicable. There's that saying, a rising tide lifts all boats. And I think that that's something you will see in the next 15 to 20 minutes as I share some outcomes. We like to talk about, each letter of Unite represents 5 interacting work groups, but we like to talk about Unite in terms of where we focus. So Unite is a people-focused and data-driven initiative focusing on health disparities, minority health research, our own internal workforce, and the external workforce. Why health disparities, minority health research? We have an institute for that. Well, we've known for decades that there are differences in longevity by race and ethnicity, with African Americans and Blacks lagging behind the total population, whites usually being used as a standard, but Latinos having what's called the Latino paradox, with better longevity in spite of a similar comorbid burden to African Americans and Blacks with hypertension and diabetes. And we're seeing with the pandemic that everyone was suffering loss of longevity. In fact, it looked like Latinos, Hispanics were losing their advantage. And we felt that we couldn't just continue to stand back and admire the problem, that we needed to do more and add to and augment what NIMHD is doing. So within a month of publicly unveiling Unite, we announced the opportunity for transformative research to address health disparities and health equity, committing up to $58 million. 11 awards were announced at the end of fiscal year 21, 6 in general to address this, 5 to address this at minority serving institutions, which you would think is well and fine. But the Unite group said that this is not enough. It's not enough of an investment. And so worked really hard in advocating, and a lot of folks across NIH have worked on it, and unveiled as of this year something called the COMPASS Initiative, which is community partnerships to advance science and society. It's for NIH, precedent setting, because it's the communities that are saying what it is that are problems in their community, what needs to be addressed. They will be partnered with academic institutions, 5 academic institutions, 25 communities, and all the activities will be overseen by a coordinating center that's a combination of scientists and community leaders to make sure that what's being addressed are those structural problems identified by the community. We recognize that entities like PCORI have been doing this for a long period of time, but this is a first for NIH. We anticipate about $154 million being put to this in the first 5 years, and if benchmarks are met, and if it looks like it's being successful, up to $400 million over a course of 10 years, and hopefully some nice generalizable principles that can be applied to other notices of funding opportunity. And just to give a sense of things, there have been a lot of notices of funding opportunity announcements. We used to call them FOAs, but that's NOFOs now. Since 2020, with the start of pandemic. We can't say this is just as a result of Unite, but it gives you a sense of the fact that everyone's leaning forward, trying to do better in this space, because you can see an exponential increase from 2018 through to 2022. In terms of our internal workforce, we know that we need to put a mirror to ourselves. And one of the things we've done is to do something that we call the Power of an Inclusive Workforce Recognition Project. It is a brainchild of Dr. Sadana Jackson, shown here, bottom row, second from the left. She's an intramural tenure track researcher, so she's early career, who speaks very eloquently in this stat op-ed that's shown to the right about how it's made her feel walking the halls of NIH and not seeing herself represented. NIH is just like any other academic institution where you have all of the leaders posted, the NIH directors, the Nobel laureates, Lasker awardees. Not a lot of diversity there. We may have a little, we have one prior NIH director who's a female. If things go well, we will have our second female NIH director in October or November, but other than that, not a whole lot of diversity. So the intent of this project is to represent the full range of the team that's necessary to allow that NIH director or the Nobel laureate to be successful. The scientists, the non-scientists, the early career individuals, individuals with disabilities. You see a lot of different colors and textures to this to represent that richness. And our staff have said that they feel seen. They feel good about this sort of thing. However, we're not just doing virtual posturing. Last fiscal year, there's a requirement in the performance plan for every institute and center director for DEIA. And one of those DEIA components was to develop a racial and ethnic equity plan for their institute or center, meaning that they had to step back and look with qualitative and quantitative eye at where there might be inequities, and if they found any, to address those things. And this fiscal year, they've been implementing that. When something like that is in the performance plan for the institute or center director, that means everybody in the student center has it in their plan because they have to get that director to be successful. And it's been really encouraging to me to see, again, people leaning into this. They want to do well in this space. We also looked broadly across NIH and saw that, for instance, one of the big things that we do to help staff is to give them awards. And NIH, getting an NIH Director's Award is a big deal. You don't get money, but you get a nice plaque. You get to stand with the director. You get to put it on your resume. It's a career enhancer. And yet, when you step back and you look at it, there were inequities in the receipt of these awards. If you looked at it with the racial and ethnic equity lens, and when you analyzed it more, it was largely because the awards were configured to be, or were biased towards the scientist. Non-scientists had many fewer opportunities to be recognized, and yet much of the diversity that we have at NIH is among the non-scientific staff who are key to making everything successful. So we changed the way that the NIH Directors Awards are done, and there are many more categories now that will allow broader recognition. And then the external workforce, the things that you, of course, are going to be most interested in. We have built upon an internal program led by Hannah called the Distinguished Scholars Program. The Distinguished Scholars Program is built upon two cohort recruitment programs, the Statman and LASCO programs. Why cohort recruitment? Because when you bring in groups of individuals and do group recruitment, you get a greater variety of individuals, and you also have individuals who can be supportive to each other, and you have greater retention. So built upon those, Hannah's idea was to allow the best of the best who can articulate and demonstrate a track record of interest in DEIA, didn't have to be their research area, to get extra mentoring and support, more money for their institute, for their lab. And this has been going on since 2018. This is the first gathering of the Distinguished Scholars last fall, first in-person one since the pandemic. As you can see, we're very carefully holding on to our masks because one of our first times all schooling together. And the data are very encouraging. My colleagues always say, Marie, point out the percentage of underrepresented scientists in the tenure track program at NIH by race ethnicity was going down progressively from the mid-90s to 2010. You add the Statman and Alaska programs of cohort recruitment, and those numbers, those percentages started going up. You add the Distinguished Scholars Program, it went up exponentially. Similarly, when it came to female members of the IRP intramural research program tenure track, there wasn't a downward true slope, but it was definitely accelerated percentage-wise by the Statman and Alaska programs, and further accelerated by the Distinguished Scholars Program. So building upon that, NIH has offered the opportunity for academic and research institutions to do cohort recruitment of early career scientists with the idea that you have to look at your own environment, make sure it's a receptive one. And yes, Mount Sinai is among the leaders in the first cohort. You have high resource institutions, low resource institutions, a collaboration between Tuskegee University and University of Alabama in Birmingham. In the second cohort, again, high resource institutions, low resource institutions, a collaboration between University of Maryland, Baltimore and University of Maryland. And the third cohort, collaboration between University of Texas in Dallas and University of Texas Southwestern. Again, some high resource, some low resource. We're very excited about this. There are basically 15 cohorts. There'll be 150 faculty at least, if all of the institutions are successful, who will be shepherded through to being tenured faculty member, hopefully with NIH R1 grant funding. Morehouse School of Medicine is the Coordination and Evaluation Center. Additionally, we thought it important that people know that there's the opportunity to report if they're seeing or experiencing problems with discrimination and harassment. And so one of the early things that was done was to make sure that that portal is very prominent on the NIH Grants website. If one reports something, one can do so anonymously. NIH has a process for evaluating things, following up with institutions. We, right after we unveiled Unite publicly, we also had a NOFO that was released by the NIH-wide Brain Initiative called Plan to Enhance Diverse Perspectives, that was incorporated into the scoring of the RFAs put out by the Brain Initiative. This is seen to be potentially a real game changer in helping to make sure that lots of different scientists are involved in projects, because it requires the applicant to indicate what they have done to bring in diverse perspectives, whether it's diverse by geography or by discipline or by race, ethnicity, gender, disability, rural, socioeconomic status. All of that is valued and important and expected in those RFAs. And we have been very impressed with this and are looking to broaden it to multiple NOFOs that are put out by NIH. And then in terms of NOFOs, there are several. that have been released. One that has been enhanced is the Science Education Partnership Awards, which is a grant to R25 to support K through 12 STEM education. It previously was only led by the National Institute of General Medical Sciences, but it was felt to be important to expand it because there's quite a bit of diversity in the K through 12 population, and science identity is often developed as early as middle school. So 20 institutes and centers and offices have joined into this opportunity. A new opportunity, something called Research with Activities Related to Diversity, or the Reward R01. This is for someone who does not have NIH funding, but has a great interest and track record in DEIA. It's kind of an accompaniment to the administrative supplement that I described to you for excellence in DEIA mentoring, but this is even better because you get to have funding for 4 to 5 years, whereas the administrative supplement is at best 1 or 2 years. Of course, to get an administrative supplement, you have to already be funded. An instrumentation grant program was developed for resource-limited institutions, which is often institutions that have quite a diversity of trainees. This allows for funds to be used for research and science education. And something called STRONG, Strengthening Research Opportunities for NIH Grants initiative has been released, has multiple submission dates, will be active for 3 years, allows, again, resource-limited institutions to step back and determine what it is they need in their research environment and to strengthen it and to develop an action plan. Things that are under development, basically concepts that have been approved by the NIGMS Council, and once a concept is approved, in most cases, it ends up as a no-go. It can sometimes take a long time. Sometimes it doesn't make it. 90% plus make it into a no-go. One is an institutional climate assessment and DEIA action plan development grant. It's first light from my viewpoint because it doesn't provide the money for the cohorts, but it does allow for the climate assessment. And for those institutions that weren't successful in getting a first grant, if they can get some private funding to bring in the cohorts, they basically have a first initiative if they get this. There's also a research capacity building program to enhance workforce diversity concept that was approved by the NIGMS Council that would allow people to act on the plans that they might have developed through the STRONG initiative. And then there's a DEIA prize competition that my team is leading on behalf of Unite and NIH. It's a total purse of $1 million. We anticipate up to 10 institutions getting $100,000 each to talk about what they've done to bring about transformative culture, systems, projects, and processes that have led to measurable change for a more inclusive environment. So we announced this in April. Submissions are due September 26th. Institutions that didn't register by September 12th, unfortunately, that was yesterday, will not get a chance to compete. We had a really nice, robust response to the registration. And we will announce our winners in December. So I will remind people who will say that they don't see themselves represented in what I'm talking about with Unite of this quote from the Reverend Dr. Martin Luther King. But before I read the quote, I'd also say that if you want more details, because I went through this very quickly and there's just such richness, so much that's going on, I would encourage you to go to the Unite website, take a look at the progress report and everything else that's there. I usually just Google NIH Unite. But as Dr. King said, injustice anywhere is a threat to justice everywhere. We're caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly. And as you can see, lots of things have been developed and they're broadly applicable. This rising tide is raising lots of ships. So I hope I've given you some data that is helpful in thinking about why we should focus on diversity, that you have a little more familiarity with the NIH DEIA strategic plan and might spend some time going through it because, as I said, it's a framework for future NOVOs. You have a sense of what we do in the COSWD office, and I hope you'll sign up for some of our seminars if you haven't already. and an overview of what's of late going on with NIH Unite. And if you would like to connect, just diversity.nih.gov is the best way to find out about our newsletter, our blog, all sorts of things. So I would be happy to answer any questions at this point.
Dr. Bernard, thank you so much. I think everyone is having the same reaction I did to learning of all of the initiatives and activities going on within NIH to really move DEIA forward. We do have a few questions from people who are on the call. So I guess I'll just take them in the order in which they came in. And I think this goes back to some of the data you presented early on in your talk. Did they look at the type of study, e.g. RCTs versus guidelines versus observational studies in those initial in that initial data you presented about the diversity of authors leading to more impactful publications? How much detail was there about the type of article?
Yeah, they really looked in a gross fashion. It's 2.5 million articles, and they had this really neat tool for this, looking at the ethnicity. So no, it didn't get that granular, nor did the COSWD study with 5 million articles. There's a lot of room for doing more inquiry here. And we're talking with our colleagues at NIMHD about how we might stimulate something like that, because there's 5 times, 20 times more data in the business sector that shows that diversity leads to greater creativity and innovation. Of course, in the business sector, you can see the outcomes more rapidly. You either sell your product or you don't. You make a profit or you don't. Whereas when it comes to developing a great new intervention scientifically or a great new clinical outcome, it takes a while. But it would be really great for us to have a lot more to talk about.
Great advice, particularly to some of our junior faculty, for the kind of research that would make a contribution while you're waiting for that 5-year study you're running to produce results, to actually think about some other kinds of contributions you could make to the literature. We have another question. Okay, refers specifically to slide 19. I don't know that you have them memorized by number.
I can pull it up and see.
But it talks about closing the gap for Hispanic, Latinx, and Black African Americans between the STEM workforce and the U.S. population percentages. Mm-hmm. Does that necessarily mean a negative impact for white and Asian ethnicities? Or would NIH increase R01 funding to prevent a negative impact? What an interesting question.
That's a great question, especially when we're looking in fiscal year 24 to a flat budget, and fiscal year 25 of only a 1% increase from what I'm reading in the Washington Post and the New York Times. So yes, it's recognized that getting funding is a very competitive environment. And it's recognized that people can see it as just this tiny pie, and if you let other people in, then there's less of the pie for me. But what we're seeing is that there's a lot more in the way of collaborative research and team research, and having, being successful in getting our money requires many times that you have that collaborative and team research. And you're going to have a better team if you have a lot of different perspectives there than if you have a very homogeneous team that's looking at things. So I don't think it should be seen as the pie shrinking because there are others who are going to be there. I think it should be seen as expanded opportunities to be successful in getting funding from NIH, because if you don't have those differing perspectives and a good team to come up with good ideas, you're not going to get funded. Yeah.
Thank you. Now, there are actually 2 very similar questions, and I think this is on the minds of a lot of people. and that is, how might NIH's DEIA efforts change in response to the Supreme Court ruling that bars academic institutions from considering race in admissions? There seems to be a general consensus that this ruling will significantly erode DEI efforts across multiple industries, including science and medicine. What do you think about that?
So yeah, we've been very aware of the Supreme Court decision, and we're waiting for further analysis and interpretation. But the reality of the matter is we have not funded based upon race. So, from that perspective, we don't see an immediate impact. We recognize that we do need to, carefully step back and make sure that there's no appearance of that in the things that we're doing. But everything that I just presented, when we talk about diversity writ large, it's not focusing on one group. We may be looking at things with a racial and ethnic equity lens, but the things that we do to address that are broad. A great example internally is that issue of the NIH Directors Awards. It wasn't that we developed a new category so that African Americans, Blacks, Hispanic, Latinos, et cetera, could get awards. It's that we recognized that it was related to the job categorizations. When it comes to the NOFOs that we've recently released, we're definitely focusing on, in many cases, resource limited institutions, because those are institutions that will have oftentimes an enriched population of individuals who come from underrepresented groups. But we're not focusing on the demographics per se. We're focusing on the resources the institution has, the mission of the institution, that sort of thing.
Thank you for that. Now, here's an interesting question, which actually I've been in a number of conversations recently, and I'm interested to get your take on this. And this says, just a comment, not everyone who is Hispanic has embraced the X in Latinx. And I know this is certainly a conversation that we had very recently at IHER, that first of all, most people I know from this background do not embrace the word Hispanic at all. So that's a completely sort of government-driven term. Latino was challenged because it's a gendered word. And I think that's what led us to Latinx, which I think many people who would be in that category object to, because X is not a sound that is used in the Spanish language. And so it really seems not to be true or authentic to the group that it's describing. And so we have Latine with an E, so that it is non-gendered, not Latina, Latino. It's a fascinating example, I think, of the way language changes and evolves. What do you think about this? Where does NIH stand, and how can progress happen if people are unhappy with the term Hispanic? I think everybody's unhappy with that term, but what do you think about this?
It is a tough one. I mean, we are working on a blog that we interviewed one of the leaders at NIH, who was born in Mexico. Spanish is the first language, and that leader used the term Latinx recurrently in the interview. And others who reviewed it said, that's not acceptable. And there is no consensus at NIH. When we went to look, there's an NIH style guide, and look to see how things should be referenced. You found many times it said Latinx, but yet I've heard from Eliseo Perez-Tablas, director of the NIMHD, he doesn't know what it means. So I think we're going to have to continue to have conversations and continue to listen and try to hear what people say and see what sort of consensus is achieved. And yes, Hispanic, Latino is in the census data. And so that's what we end up referring to. So things will continue to evolve. I know that, for instance, the census is considering a new categorization that would allow us to consider Middle Eastern and Sub-Saharan Africans.
Yeah.
A group that's not been well represented previously. I know that we need to do a much better job of gathering consistent data about LGBTQ plus populations, and have to have at least we have a National Academy study that has some recommendations as to how we might consistently gather those data. But it's an ever evolving landscape, and we have to listen, we have to be respectful, and we need to understand that, give people grace if they don't say things properly, because people are usually trying their best and not knowing necessarily what the best is. Yeah.
Okay. Well, it personally makes me feel better to hear that NIH is struggling with this just as we are. And I think you enunciate the exact right principles, that we have to listen and be respectful and try to understand and wait as a consensus evolves. I think that's exactly right. There's a very specific question, but perhaps it could serve as an example for other similar organizations. How can the National Latino Behavioral Health Association become involved in COMPAS?
So unfortunately, all of the applications, the application process for this funding has already taken place. The reviews have already taken place, and they probably will be announcing the those that have gone through this peer review process most successfully in the next several, the fiscal year ends in 2 weeks, so they'll probably announce it in the next couple of weeks. But once announced, and you know which organizations have gotten the funding, then making outreach and seeing how one could collaborate would be very appropriate, I would think.
Okay, thank you for that. So my apologies for the questions that we did not get to. Our time is coming to an end. I want to again thank you, Dr. Bernard, for joining us and sharing with us really the NIH vision for how to move forward. I think it represents a lot of food for thought for individual organizations to look at what NIH is doing. And of course, there were a number of opportunities that perhaps people who are listening were not previously aware of, that NIH is now putting out to really move these issues forward. So thank you so much for sharing your time with us. Thanks everyone who joined us on the webinar. We look forward to seeing you at our next IHER seminar in October, and enjoy the rest of your evening, everyone. Thank you very much.